a couple of years now, right? And I think it's been a journey, but now we're at a point where we've got leadership support. We have some technology investments that have been made, and we have the right researchers and providers that we think are world class to really do something with what I consider some of the best data in the world. And so we're going to talk a little bit about what that vision is. We're going to talk about how we're implementing it with a couple real world applications, and then where we need your help. And again, I've got about 15, 20 minutes. So we're happy to take follow-up conversations and any sort of questions you have after the meeting as well. So I wanted to start by just giving this a very broad overview on our strategy at Emory for data and AI. And there's basically two components. There's building the data foundation. So when I got to Emory, it was clear that we needed to work on what is the data quality across Emory, and how do we make sure that the data that exists is not sitting in silos so you can't access it. So I had a lot of questions around access, a lot of questions around how do we get access to data. And so we wanted to make sure that we built the data foundation in a way that our end users, which is each of you, can access the data. We also want to make sure there's cross-enterprise data governance. We've stood this up, and many of you are part of that cross-enterprise data governance. When we talk about data governance, it's really the key theme is how do we enable, right? It's not to control, it's to enable the team to do things more efficiently with data. Changing the mindset is more about the talent that we're bringing to Emory, and also the culture of Emory to become more data-driven. We just implemented a Microsoft Copilot instance for Emory only. John Ellis, who's here today, and his team helped implement that. So everybody in this room has access now. If you have an emory.edu or an Emory Healthcare login, you can actually go to copilot.microsoft.com, and you've got an Emory only instance of Copilot, which means your data's safe. It's not going to be shared outside of Emory. And so we wanted to provide that for all of our physicians, researchers, students, faculty. So there's something that you've got now that you can leverage. That's just one example of changing the mindset. We're also recruiting and hiring new talent. My team, we've got some amazing new talent from the CDC, from other academic medical centers, from Google. And so we're trying to make sure that we have a small but mighty team that can actually focus on helping to enable this data sets. Unified data platform, we're going to talk about that. Responsible AI is a big topic at Emory. We've got a committee now that we've myself and Lanny Libeskind, who's the Senior Vice Provost for Academic Affairs, co-chair that. And the idea behind that is how do we make sure that our data is treated in the right way? How do we make sure it's responsible? And how do we make sure that we can defend the use of that data should there be some issues down the road? And so that's a really important component of our strategy. Beyond all that, so that's what I would call the non-sexy stuff, right? The fun stuff is the top, which is leapfrogging with technology and AI. And I think this is a really good opportunity for Emory because we're not encumbered with a bunch of legacy technology. So at many of our academic research institutions, there's legacy technology that actually is going to inhibit the future potential of AI. We were just in a conversation with Snowflake this morning, John Ellis, Mike Goodman, and a few of us. And it's nice because we've almost got a clean slate now where we can actually use AI in a way, and we can use it from a position of leveraging all the mistakes that many of others have made. And now we can actually move more quickly using AI than we could have probably 5 to 10 years ago. So it's kind of good news, bad news, right? The bad news is we didn't make the investments in technology, 5 to 10 years ago. The good news is now we have in the last 6 months and 1 year. And as a result of that, we can benefit from some of those learnings from others. So that's the strategy. Unified data platform. Has anybody heard that concept at Emory? Anybody here know what that is? John has. John Ellis. I know John has. A couple of people have. So this is something that's going to hopefully help change the way that we actually use data at Emory. It's going to be used for academic, faculty, researchers, and providers. One single common data platform. Some of the key themes around it are Epic. Anybody in here use Epic? Anybody has used Epic? Okay, good. So we have a fair amount of Epic. So Epic is going to be migrated to the cloud, which makes data available within our cloud environment. Sectra, I'm sure you know Sectra, right? Digital pathology and imaging. We've got contracts with Epic and Sectra as part of this. We also we're going to keep a multi-cloud environment. That was really important in our discussions to enable flexibility. It's also going to help us enable the cost point to be reduced. So in this particular case, what we've talked about is if we actually use our data centers versus our cloud technology stack, we've actually are going to be able to at least be net neutral, maybe even save Emory money from the infrastructure costs. We're also going to provide more flexibility with GCP, AWS, and Azure in terms of our tools that are going to be available to researchers. We've got NVIDIA at the table from a high performance compute perspective. And I think NVIDIA is really excited. I just got notice that they want to come meet with us individually, and we want to be potentially one of their first partners in healthcare and academic research. And I think that's a testament to what you all are doing. They see us as sort of the future of healthcare. And you can see some of the data that we're going to have as part of this unified data platform. So, social determinants of health. Danny, who runs the school, runs Rollins. This is the data that sits in this building. And we've got digital imaging data, genomic data, which is a really big passion of mine, and then synthetic data, which we aren't talking a lot about at Emory, but I think we need to be, right? Because there's a lot of interesting, compelling use cases using synthetic data as well. So all of that's going to sit within the unified data platform. You all will have access to that. It's got basically three components: talent, I call it the three T's: talent, technology, and training. Talent, what we're doing is we're going to create a small team of data and AI professionals that are going to hopefully help empower each of you. We're going to make sure that we're democratizing the tools to our faculty, research, and staff. I don't believe that we can actually control and centralize it. I think we have to empower and enable, because the world is moving so fast. Like every day there's a new article coming out on AI and precision medicine, and Anant, you've got a few articles like every day like coming out. So how do we enable, right? How do we enable that and enable each of you? So we're getting a small team together to do that. Technology, we talked about hybrid cloud, we talked about Epic and Sectra, and multimodal data. That's like the holy grail. That's what everybody's trying to do, right? Training is actually one of the most important pieces on this page. When we were presenting this to the board, this use case, one of the things that June Lee said, and Ravi Bamkanda agreed with, is that out of everything on this page, training was probably the most important, because if we have this really interesting technology but nobody's using it, then we've all failed, right, as an institution. So how do we make sure that we've got the right training, both for power users like yourselves, who probably need a little less training but probably still need to know how to access and use it, and then all the way to our nurses and our clinical care teams that maybe need a little bit more self-guided. We call it more of the TurboTax approach, self-guided TurboTax approach. So this is the components of UDP. And what I thought I'd do is sort of show you a demo of how it's going to work. And I think this will help bring it to life for you all. Let's see. You said go to Edge, Chrome. Oh, Chrome. We're going Chrome today. Okay. Good. Let's see if that works. So this is just a mock demo that will hopefully give you some of the use cases that we've got. Let me just try to see that. Okay. I think it's pulling up. So again, everybody's going to have their, I don't think it is pulling up. Let's see. Do we have it in this one too? In Edge? Okay. Just try that. I'll try it one more time. It's kind of working. We'll go with it. Maybe it's not. I'll let you play with it. So yeah. So let me pause there while she's fixing that. Any questions on unified data platform? I can see I stand behind this. I'm not good at this standing behind here. Questions on unified data platform? I'm sure you have some questions. We can take some now. Yes.
About sort of the access patterns of like usage patterns. So like I buy a server, I put $5 grand on it forever, and something takes a long time to run. Whereas in the cloud environment, I have no idea how much anything costs to run any of my instance.
Mm-hmm.
And I wasn't sure how that works for research. Fixed budgets, but unknown costs.
Right. So we're going to continue to have on-prem, the back to flexibility. So you'll continue to have that option. You'll also have the option to leverage Microsoft Azure. When it comes to the actual cost, we're going to be helping you to understand if there is cost. That cost for unified data platform will be centrally managed, right? Meaning that cost will sit within, it's a complicated answer, but somewhere within the Emory digital, Emory IT budget with John Ellis and Alistair Erskine. So hopefully that also helps you not have to worry so much about that, right? So we want to create an environment where you're less worried about the infrastructure and the cost, and we sort of give you the flexibility and the options to hopefully use those tools to your benefit. Good question.
On the website, bring up information about a supported free resource at AWS, and you can start workloads. It's kind of first come, first serve. We have GPUs in there and stuff like that, and you can run your algorithms and see what the cost of price.
Just go with Edge and see if it works.
What was the first one you said?
It's not letting me.
I
Go to the internet.
Okay, other questions? Not you had one. Yeah.
Well, I'm just maybe Joey,
Oh.
speak to just generally about data access, and you know that we have the partnership that we signed last year with,
Inference.
Inference,
Yeah.
the Pramana. Just generally, sort of how do you see access to data? Because I know that's been one of the big pain points. Generally for researchers, certainly, you know, at Emory, I suspect clinicians as well.
Yeah.
So just in terms of the communication about how to access data, right? Obviously, it's got to be done under data privacy and so on. But there still seems to, at least in my mind, and echoed by several other collaborators, there still seems to be a lot of ambiguity with regard to how to access data.
Mhm.
And just sort of, will you speak to what the plans are, general strategies are, and how inference potentially might help alleviate some of this?
Yeah, so Inference, we signed an agreement with them. Now the good news is, you know, our raw data is still our raw data. We still own the IP for that data. If we decide to leverage Inference, what it is it's a collaboration that allows us to collaborate with Duke and Mayo Clinic and Cleveland, some of the other institutions that are in there. And Inference actually de-identifies the data for us. They provide the tools to be able to leverage that de-identified data. They're doing that de-identification on their dime. So back to the cost aspect, that's something that Inference is taking care of for us. The reason we did that is number one, we wanted to make sure that we allowed a de-identification strategy that hopefully is going to make things easier. The issues with de-identification, as you all know, is with the advent of AI, it's actually much easier now to re-identify, right? So now there's actually bad actors that can re-identify our data much easier. So Inference is what I would consider, you know, a bit ahead of the curve in that regard, right? The second thing is it allows us to collaborate with those other research institutions and have access to their data as well. So we will have a path to use that for all of our researchers and faculty. We will also have a path for us to continue to de-identify our own data, or you can continue to de-identify your own data if that's what suits you. One of the main things that we want to make sure of is that data, that raw data remains ours and the IP remains ours. And that was the key components of that deal. So I want to say that our first, you know, MVP pilot is actually going to be in September. So when Inference is ready, what we'll do is we'll share that. We'll have a bunch of lunch and learns, and we'll teach you more about how to leverage that relationship. I can tell you, in talking to Duke and Mayo in particular, I saw them actually in Washington, D.C. last week. They're very, very bullish on Inference ability to de-identify data. They've told me it's a game changer. So I'm hoping that we get a similar reaction here at Emory. So that's a good question. Yeah, go ahead. Mhm. Yeah.
So like, I can always know if I've seen something before, I should get rid of it, but DICOM is always a disaster.
Yeah.
The outside imaging is less of a disaster. People can still do weird things. And so as a researcher, I've been, even on my grants, I'm 99.9% sure that I've identified everything. But from like I'm gonna get sued thing, that's not good enough at scale. So as part of the inference thing, we can sort of isolate that it's their fault. And, oh well.
There's a little of that, right? Technically, it's still our data, so we'll be somewhat at risk. But yes, like that will help limit some of the liability back to Emory and our researchers for sure. Yeah. So good question. So we're not going to have the demo today, but we'll send it out post. These are the 3 use cases that we're going to be able to enable. The one that I'm really passionate about is, number one, we can actually start to use outside data. This actually at the third one on the right, air quality risk analyzer. So this is pulling in outside data, including from the CDC and others. We've had lots of conversations with them, plus our internal data. So if I look at our data within Epic, I can actually see within our hospital systems what's happening. So for example, let's take air quality. Yeah, I can see within our hospitals how much asthma cases. I can actually start to predict it, for example, what the impact is on air quality back to the CDC and vice versa. So the combination of taking external data sets and then our own internal data sets, it's really, really powerful. And actually, most of our external partners, like the CDC, are really interested in that data as well. So that's one use case that's going to give researchers access to the ability to hopefully be able to provide better predictive capability for how our patients and our communities are going to be affected by certain trends in the atmosphere. The second, let's see, so we're talking a lot about cancer screening and treatment. So how do we leverage AI to be able to do that? That's part of a use case that we've got as well. It's particularly in more rural areas. The third is probably the holy grail for me, and this is the reason I joined Emory. This is about, when you look at this demo, it's basically what we're pulling in is social determinant of health data. So within Epic, we now have the ability to see if a patient is having, access to transportation issues, or they have, food issues. They're not able to get access to food, or they're also drinking, or they're smoking, right? Some areas around social determinants of health. We know that data is really, really powerful to predict clinical outcomes, right? We also have genomic data, particularly in Winship, we have genomic data. And so if you look at the genomic data that we have, and we can actually start to classify it against the social determinant of health data, you can pretty quickly get to a predictive risk score for what that patient may also be susceptible to, other disease prototypes, et cetera. So for example, the demo that we have in the UDP prototype is acute myeloid leukemia patient treated at Winship. Social determinant of health data shows that she or he also has, low financial means, no transportation, and drinks and smokes, right? Based on the genomic phenotype, they have P53 mutation that we know, based on the classifications, will likely be, diabetes, potentially diabetic, and may have cardiomyopathy. And so those two components would go into a scoring classification and be fed back to the primary care and the researcher to say, hey, this patient needs to be screened for glucose screen at the primary care. And they also, we recommend that they should have an echo or an EKG to measure the heart function. And if you think about what that does, is number one, it improves the patient outcome, right? You're going to hopefully help prevent certain disease types. Number two is the researcher and the provider now has access to amazing data that you can use for research. And hopefully you're going to be more effective at treating that patient, which is what everybody wants to do. And the third is financially, obviously. This is a component around, both for Emory, you're keeping that patient in network. We can actually refer back to Epic and have that referral take place within the Emory network. So if you're the finance team at Emory, you're like, that's great. That's what we want. We want the patients to stay in Emory. And also for our insurance providers, we would actually reduce the cost of care significantly if we could actually prevent some of those diseases from occurring. So that's the whole premise behind this particular application of UDP. And I think that all of you will have a big part in that. Some other use cases that I know we were running a little bit late today, but just to give you a snapshot, Alzheimer's is a big component that's going to go into a unified data platform. These are some other ones, and we'll send this post. You can see chart abstraction, precision medicine. We've been working with several of you in the room, Tony and Gary Clifford and Anant and others on this. Mike Goodman's joined us. He leads our Gen AI capability. Mike, I don't know if you can raise your hand in the back. So you'll be hearing from Mike. He's going to help you all enable this. We've got a couple in production around cancer registry cases with amazing results so far, 100% accuracy across 4 cancer sites, basically taking that and ingesting into the cancer registry, which is time consuming. We've got basically a 2-year backlog for Winship. So if you're Madhu or you're Ram, this is a really important use case for you to get much more accurate, timely information from the cancer registry. And ambient listening. Ambient listening is got some amazing data. We're just now tapping into it. We were one of the first health providers to use Abridge and ambient listening. And we've seen already 45% increase in provider wellness. We're saving, for those providers that are using ambient listening, it's about 2 to 3 hours per week right now. So again, really good reduction in administrative time. And we also know that we actually we're improving the way that we're treating our patients as a result of that. So those are just a few things that I wanted you to see. In terms of what we're going to be doing from a guiding principles perspective, we're creating Emory-only instances, so we're keeping the data safe and secure within Emory environment. We are partnering as much as possible, so we're picking partners that we think are going to help accelerate our growth, but we want to retain that IP and that data, which is important to you all. We call it meet end users where they are. So our goal is to work with you all to enable each of your solutions. LLMs for all. The vision eventually we have is that everybody can write their own LLM. I mean, it sounds crazy now, but in like a year or two from now, we're hoping that that's a possibility. And the responsible AI core. And just to close with this, what we need from you all is, we have opportunities to be the voice of the end user. So we'd welcome nominations for anybody that wants to be part of the Responsible AI Committee. We'd also love to see any contributions to our Gen AI and LLM use cases. I think we have like 98 use cases already collected from you all. So we're getting those in, we're prioritizing those, and we're actually executing on those as we speak. And then we talked about co-developing our solutions together. We want to work side by side to make sure that we can do that with you. Last thing I'll close on is we spent some time in Washington, D.C. last week. And one of the things that we talked about is the ability now for Emory to be at the table in some of the AI policy making is something that I think we should all be excited about and proud of. And also we should be making sure that your voice is as part of that process. So we were last week with 20 people sitting with the director of human health services and the federal lead for AI, chief AI officer, and several of the senators' teams, so their staffers. And they're asking us, you know, there was technology providers there like Epic, there was us, there was a couple startups, and then there's Stanford and UC Davis, and they were asking us for our recommendations on policy. And the good news is they're listening to us, right? So they're trying to figure out how do they set policy in a way that's not going to stifle what we talked about. It's not stifle innovation, like stifle this team here, right? How do we create policy that's going to help enable our patient experience to be better, patient outcomes to be better? And how do we ensure that our rural hospitals are not impacted by, you know, overregulation? And so I mentioned that to you all because I think it's important to think about this in, you know, not just the Emory landscape, but we're now leading some of the national agenda and the policy around that. So if you have ideas or questions or any ways that we can help make your job easier, just do let us know. So with that, I will see if there's any final questions and any questions for.
Yeah, a question about the deck. Actually, I got one too. People wanted to know if they could get the deck, and then is there an opportunity in the future to see the demo if it wasn't able to show?
Yeah, for sure. No, we'll definitely show the demo. We've got a lunch and learn planned on the demo for Unified Data Platform in a few weeks, and we'll definitely show that there, and we'll make sure that you all are invited to that. We'll share the deck as well. So absolutely happy to do that. Other questions? Okay, very good. Well, thank you all so much. We appreciate it. Thank you.
All right. Next up, we're shuffling the order a little bit. Next up, we have Dr. Kevin Kalinsky. He's a professor in the Department of Hematology and Medical Oncology, where he's the director of the Division of Medical Oncology. He's the Louisa and Rand Glenn Family Chair of Breast Cancer Research at Winship, where he serves as the director of Breast Medical Oncology and the Glenn Family Breast Center. Let's welcome Dr. Kalinsky.
All right, it's good. What a great attendance. So I'm going to go in the weeds. So I'm a breast cancer doctor, and I just wanted to talk about, we have a number of ongoing studies with Anant and his colleagues. I wanted to give a sense of just some of the specific work that we're doing. So really, I'm going to go in the weeds, as I said, but I'm happy to talk through any questions, anything like that. And I'll keep some of this general because I know all of you are not breast cancer experts. So in breast cancer, you know, we've had a number of therapies that have been approved in the last several years. This is an ever-evolving field. And part of the issue that we are facing is that it is hard to discriminate who is most likely to benefit from said therapies, as well as who is likely to have toxicity or not. And this is a major issue because a lot of our agents that have been approved recently don't have specific integrative markers to tell us who's likely to benefit and or not. So one example of this is we have drugs that are approved for our patients with estrogen-driven breast cancer, which is our most common subtype of breast cancer. There are 3 of these drugs that are approved. These are oral drugs. And now they've started to be approved not just in metastatic breast cancer, but also early stage breast cancer as well. And one of the things that we've seen is that there also appears to potentially be a difference in terms of race and ethnicity, in terms of tolerability as well as efficacy from these drugs. So we have one study that we are looking through now where we are collecting data. This is a retrospective study, again, for patients with metastatic disease that is estrogen driven. These drugs were approved in the middle of 2000 teens. And so we are looking at all of these different variables, again, metastatic disease, to see not only can we determine who is likely to benefit from these drugs when we incorporate radiomics and also pathology from an AI perspective, just to look at outcome, look at how long patients are on, whether we can see a difference in survival, see whether or not we can determine who's likely to develop toxicity or not. You know, one of the side effects that we can see from these agents include pneumonitis, inflammation in the lungs. So it'd be great also for us to see if that is one thing that we can detect early, because that can be a life-threatening toxicity. Okay, so I have 3 more examples, and then I am open to discuss anything. There's no topic that's off limit. All right. So another series of drug are antibody-drug conjugates. These are exciting drugs, in not just in breast cancer, but in cancer in general. These are essentially antibodies that are linked to chemotherapy. There have been a number of these drugs that have been approved in breast cancer, urothelial cancer, lung cancer. The way I describe these drugs to patients is essentially you can think of this as like a GPS, where the way that that tells your car where to go. This essentially is an antibody that is linked to a chemotherapy and directly delivers those that cytotoxic to those cells. So one of those drugs that we have available now is called trastuzumab deruxtecan. And we also have a second drug that's called sacituzumab govitecan. But one of the issues that we're facing in clinic is that we don't know how to best sequence these drugs. And the other thing that we have seen is there's some specific toxicities that we can see with some of these drugs. For instance, I talked about pneumonitis, which we see with the CDK4/6 inhibitors. We see that being about maybe 3 to 5%. With trastuzumab deruxtecan, that rate is higher, it's 10%. And when this drug was originally developed, we saw that patients could die if that side effect was not detected early. And so we're hoping to incorporate radiomics as well as pathomics, one, to determine the best sequencing of these drugs, but also to detect toxicity as well. The third type study is, there's been a lot of focus, not just in breast cancer, but all cancers, about immunotherapy. And so we're all on the same page here. Immunotherapy right now is an intravenous infusion in solid tumors. This is primarily checkpoint inhibitors. These drugs are approved in 20 plus different types of solid tumors. It's what Jimmy Carter was getting for his melanoma. So in breast cancer, this is approved for patients with triple negative breast cancer. And for patients with early stage breast cancer, stage 2 and 3 breast cancer, this is approved with chemotherapy. So you have a patient with stage 2 or 3 triple negative breast cancer, which is our most aggressive subtype of breast cancer. And then we give chemotherapy and immunotherapy upfront to these patients. The problem is that we have no other indicators for who should be getting this therapy or not, right? There's no tumor-based analysis that can determine who is most likely to benefit from these drugs. And so we're likely over-treating some patients with stage 2 and 3 triple negative breast cancer because we don't have any other markers to determine who's likely to benefit. There have been some imaging-based biomarker studies. A number of these have been in lung cancer. Some of these have been evaluated in neoadjuvant triple negative breast cancer, meaning along with chemotherapy, but not so much with immunotherapy and chemotherapy. And so right now with an Emory, we have about 300 patients or so who've had chemotherapy with or without immunotherapy. And so we are looking at different characteristics with Anant and his group, where we're looking at breast imaging, we're looking at systemic imaging, just to see if we can identify who's likely to have toxicity. Again, pneumonitis, you can see that there's a theme here of the long toxicity that we can see with some of our agents, but also to look at the path and to see whether or not there's a discriminator of who's likely to benefit or not, because we don't have anything right now in the tumor tissue that lets us know who is likely to benefit or not. And this sort of approach is the measure that we're really looking for, the outcome that we're looking for is when patients go to surgery, do patients have a pathologic complete response? Meaning, is there nothing in the tumor tissue or nothing in the lymph nodes at the time that they go to surgery? Because patients who have a pathologic complete response, meaning there's no cancer left, are likely to have a survival benefit. So that's an intermediate endpoint that we can always look at. And then the last study that is a little bit near and dear to my heart is, in breast cancer, for patients who have estrogen-driven breast cancer, it used to be that every patient who had a lymph node involved, back when I was in training a long time ago, everybody would get chemotherapy. Everybody, like if you took the boards, every patient, ER-positive, estrogen-driven breast cancer with a lymph node involved, everybody got chemo. So there was a study that we reported a couple years ago now, where if you had estrogen-driven breast cancer and you had 1 to 3 lymph nodes involved, we used this tumor-based test that's called the Oncotype test, which looks at 21 different genes of the cancer. It's a commercially available test that's been around since the mid-2000s. And if your score was less than 26, patients were randomly assigned, 5,000 patients, it was a global study, to receive chemotherapy followed by endocrine therapy versus endocrine therapy alone. Because the question of this study is, could we use this tumor-based test to determine who's likely to benefit from chemo or not? And what we saw is that patients who were premenopausal, they benefited from chemotherapy. All of those patients seemed to benefit from chemo. Postmenopausal patients, which were 2/3 of the patients, there was no benefit from chemotherapy. And there's been a lot of controversy from this study of why are we seeing this difference between pre and postmenopausal patients. But the reason that this is important from an AI perspective is that this test, this commercially available test within the US, is not widely available. It costs about $3,000 to check this test. And so this is something that our patients in the US have available in some Western European countries. But, for instance, in Eastern Asia, they have their kind of derivative tests. In Latin America, it's not available. Africa, it's not available. And so, Anant and his group have worked already within our group, within our cooperative group, to validate their signatures based upon the tumor tissue, right, what they see on an H&E, to discriminate who may benefit from chemotherapy or not in this study, in a different study that was actually the precursor to this trial. But we're hoping to bring this over to this study because, this is a modern study. And, could we live in a world where, different countries have different path that's available to them? But if there's a way that we could have access to a cloud and those H&E slides could, then be read and we identify some sort of signature, is there a way that we could use that sort of signature to inform who needs chemotherapy or not? This has real global patient impact. And so these are just examples of ways that we can discriminate and potentially utilize AI, either with path or imaging. Just wanted to give you a flavor of some of the things that we're talking about within Winship, within Emory. And I'm happy to answer any questions that you may have.
Yeah,
Yes.
So one is general question. It's always intrigued me that Oncotype DX, which was so successful with ER-positive lymph node negative tumors, just is not, in spite of all the aspirations to create a signature across colon and BCIS, and I know Dr. Patel here was involved in the development of some of these signatures. So I've got a two-part question. One is, it's interesting that there isn't an Oncotype or molecular test for a lot of these other indications you mentioned.
Mm-hmm.
Talk about our exponder and using Oncotype there.
Mm-hmm.
One is, why is it that there haven't been more molecular genomic-based tests for ADCs, for IO, for other indications? So that's one question.
Mm-hmm.
Second is inward looking. A lot of buzz around AI. Ultimately, we want to go beyond just writing the papers. We want to get this into your hands so that you can make clinically actionable decisions. what do you see as the pathway internally within Winship and Emory to get this to a point where you then feel like you can trust this?
Mhm.
You sort of have a vision of what are the various studies that need to be conducted internally
Mhm.
so that we can get that.
Yeah. So I think those questions are related to one another. You know, within medical oncology, there are different steps to achieving clinical utility, right? So there's analytic validity, and then there are different steps, you know, is there reliability, and then ultimately achieving clinical utility. And so for us in medical oncology, in order to achieve clinical utility, it's not so much these prospective retrospective studies, because they're an example of other tumor-based tests that we have great consistent prospective retrospective data. Like, for instance, there's a tumor-based test that lets us know whether we should be extending hormonal therapy beyond 5 years or not. And that hasn't had great uptake because it wasn't included as an integral biomarker in various randomized studies. And so that is why we've seen uptake of some tumor-based tests, but not others. And, you know, I think for us, the pathway that I think is best for us to kind of think this through is for us to look at data sets that are within Emory for a number of reasons. One, we have access to these, you know, two, we have a diverse patient population. It's also worth noting that a number of these assays were originally analyzed on a non-Hispanic white population, and that has raised some questions in terms of generalizability. And so I think validating them here and then bringing them on to the cooperative groups, you know, the National Cancer Institute has various cooperative groups, similar to what you've done, Anant, right, is bring these to the cooperative groups and then try to validate them in a prospective, retrospective way. Then the question is going to be in terms of the strength, you know, whether or not it needs to be validated in multiple prospective, retrospective studies, or even just evaluated in a prospective study, which adds a lot of cost, a lot of resources. It's a lot to take a marker from exploration into clinical practice, but that's been historically the steps.
Can I extend your comment?
Yeah, please.
So one of the reasons Computational and all of these were done, in the way they were done, is because they were phase 3 randomized trial based on NCI1, that is taxpayer. All of the new ADCs are industry trials.
Yes.
So those cohorts are not available for public consumption. They are with the industry, but they are doing all their analysis on their internally, and we don't have access to. So access is a major issue.
Yeah.
What's an impediment for ADC related signatures or correctors?
Yeah, so, you know, I mean, I think that's a really important point. So as of, for instance, you know, I talked about chemotherapy and immunotherapy, how that led to us giving that for patients with stage 2, 3 triple negative breast cancer. That study was a study that was sponsored by industry. And so there have been very limited tumor-based analyses that have taken place because, you know, what's the incentive to narrow down the population that you may be treating? And so that has been a major discussion within our community of, well, we need to have a stake, and what are our stakeholders wanting? And that's why I also was saying that the best way for us to think about answering some of these questions is through the National Cancer Institute associated cooperative groups. Yes.
Questions I always have about these kind of retrospective things, we're looking at kind of baseline data. Unfortunately, it gets people on time. And lots of stuff happens, which means when you're trying to make a prediction, something could happen. Something that happens. How's that? I mean, you say more patients, but like we were using Emory patients, we have 300 or 400, and you get someone who just, for whatever reason, just stopped taking her Herceptin after a year or two. You go, she doesn't really count. Or how do you make it kind of a kosher data set, but not screw yourself as well when things that they got hit by a bus? Because otherwise you're not gonna have enough data with all these variances of the universe and treatment and whatever.
Right, right. So one, I will say, I have a few thoughts. So one is not all the subtypes of breast cancer are the same. You know, For instance, estrogen-driven breast cancer, 50% of the recurrences happen after 5 years. Triple-negative breast cancer, they all happen within 5 years. And so the biology can be a little bit different. And so the outcomes that you see can be a little bit different. But at the heart of your question is, what can you really make of smaller data sets? There is something to be said about power and larger sample sizes, and then also have a training set and a validation set. And so could one impact clinical practice just with like 2 data sets of 300 patients? No. And there have been several examples of this with some molecular-based testing. Like for instance, in our clinic, we talk about testing for subtype and looking at luminal A, luminal B, and that's part of our vernacular. But we actually don't use that test, the PAM50 test, to determine that because it's never been looked at in a large series in a prospective manner. That first study is actually happening now. So to answer your question, I do think it takes training and validation set, and that's why it also takes some of these larger studies because things happen and you want to look at an intent to treat population, and so that accounts for some of that. Yes.
Let's say we're successful in developing a model that predicts response to some drug, whatever it is, on the pathology side, so molecular data, whatever. What would be most helpful to you as a medical oncologist for where you get access to that prediction? Should that be a part of some unified pathology report? Should it be go straight into the patient's medical record? Tests? Should it be just communicated on the side via email?
Yeah. I mean, those are the sorts of things where ultimately, if it achieves clinical utility, should be in a pathology report. Like it should be something that's embedded in an electronic medical system. And I think, it also depends on the question that you're asking, right? So some of the things that we're looking at, it's the question of, do you need immunotherapy or not? Are you going to benefit from this drug? So ultimately, the establishment of clinical utility would incorporate this into a pathology report in the medical record. Any other questions? Great. Thanks, guys.
All right, thank you. For the people standing, I know that there's a couple chairs scattered throughout. If you want to take a minute or two to find a seat, if you like. But next up, we have Dr. Anant Madabhushi. All right, Dr. Madabhushi wears many hats. He's the Robert W. Woodruff Professor in the Wallace H. Coulter Department of Biomedical Engineering here at Emory and Georgia Tech. And maybe most importantly for this mini symposium, is the director of the Emory Empathetic AI for Health Institute. Welcome, Dr. Madabhushi.
Thank you. Thanks, Jordan. Thank you. Appreciate it. Thank you. It's really very heartening. I'll just echo what Kevin said. Really heartening to see sort of truly full auditorium. Clearly, we need to plan for these events in the future with bigger rooms, and also ones where we actually have card access, or you don't need card access to take the elevator. Yeah. Anyway, so I want to talk a little bit about validation of AI in precision medicine, and it's actually it was great that Kevin went before me and set the stage with some of the different problem use cases that we should be thinking about and we should be tackling. And so I sort of a little provocatively titled the talk, walking the talk, and there's a lot of buzz around AI, but, what do we need to do to really start to get serious about moving this into clinical deployment? That's my COI slide. All right. So I think I think a lot of you working in the AI space are probably familiar with these algorithms called deep learning. Congratulations to Dr. Williamson, great paper out in Nature today on using these foundation models for pathology. This is from some of our own work now almost a decade ago, where we demonstrated the use of deep learning algorithms, in this particular case, a particular kind of deep learning called stacked sparse autoencoder, for a very simple problem of trying to find nuclei, finding cells. And what was really gratifying when we started on this problem was the fact that you could train these algorithms very easily with just having a few annotations of individual cells on these breast pathology images. We were able to train these algorithms to then go in and automatically find breast cancer cells on new unseen images. So this was exciting. The first time I saw this nearly 10 years ago, it just knocked me off my chair. I couldn't believe that you could have such a powerful technology, which didn't really require a great deal of input. In fact, my student working on the problem at the time knew nothing about breast pathology, knew nothing about breast cancer, got the annotations from a pathologist, was able to train this algorithm, which was really stunning. But therein lies the rub, right? And so one of the things that we've heard about with these AI algorithms is that a lot of them tend to be fairly opaque. They're called black boxes or mysterious machines because we're really unable to understand what these algorithms are picking up, and the representations are fairly opaque. And then this, of course, in turn has led to this issue of this reproducibility crisis in science and AI. I mean, we hear about this quite a bit, and some headlines from some popular articles here around machine learning potentially fueling this reproducibility crisis. And then, of course, we've also heard with ChatGPT this issue of hallucinations, right? So the fact that ChatGPT, can give some very, very compelling responses to questions that that are posed to it. But can you really truly trust a lot of these responses? And so I was trying to explain this to my wife a couple of weeks ago, and I plugged into ChatGPT a photograph of myself, and then ChatGPT spat that out. Saying, Madabhushi, expert in medical imaging, et cetera, et cetera. And so I was trying to explain this whole concept to my wife, who doesn't work in machine learning. She looked at me, smiled, and said, darling, now I understand what you mean by ChatGPT hallucinating. Clearly, it's confused you for someone else. So, all right. So how do we address the reproducibility crisis in AI? And so what I will position here is that we need to really be thinking about interpretable, explainable approaches where we're really developing organically from the get-go approaches that integrate more explainable features. And I'll talk about a couple of these more explainable features. But like Dr. Kalinsky talked about, we have to be thinking about multi-site, multi-institutional validation. And this really has to be done across multiple sites, but also potentially leveraging clinical trials. Certainly in the oncology space, we need to be thinking about leveraging completed clinical trials that are retrospective, but then also think about really deploying these into prospective clinical trials to ultimately transition these into deployment. And so, I just want to sort of clarify also that, I don't want to dismiss AI. I mean, there are limitations with the opacity, with the black box nature of these algorithms, but they can be very, very powerful. And the kind of approach that we're taking and the work that we're doing is leveraging the power of these algorithms to go in and do a deep phenotyping of the data. So here's an example where you can leverage these approaches to go in and identify the different compartments, the different cells on these pathology images. Here's an example where the AI can be used to identify the tumor, the stroma, the epithelium, the individual cell types, and then having phenotyped the individual cells, now we can start to pull out more explainable features relating to the shapes of the individual cells, features relating to the architectural arrangement of immune cells, to the interplay between immune cells and cancer cells. So it's not like you throw the baby out of the bathwater. So in spite of the issues with opacity with the AI, our position has been, well, you can leverage them, but leverage them to really do this compartmentalization, partitioning of the images into these individual constituents, and then extract more explainable, interpretable features to drive prognosis and prediction. So let's get into a couple of examples. Some of you have probably seen this example before. This is in the area of breast cancer. Kevin set this up very nicely, so I don't have to regurgitate Oncotype DX or the molecular assay. So before Oncotype DX came along, there really wasn't an easy way to identify which breast cancer patients were going to receive benefit from chemotherapy. The problem with this test, as you heard from Dr. Kalinsky, is it's expensive, it's a tissue destructive test, and it's just out of reach for most of the developing world. In India, for instance, the cost of chemotherapy is about $1,900. So using a test that costs about $3,000 or $4,000 to tell you whether you need chemotherapy or not doesn't make a lot of sense, right? So what we've been looking at is leveraging AI or explainable AI with pathology images to try to make these predictions, but potentially in a more interpretable but also cheaper manner. And here's an example of one of the more explainable features that we've been looking at. This was work done by Haojie Lee, a former PhD student of mine, where she used AI to identify collagen on these H&E images of breast cancer. Collagen, of course, is a protein. And essentially what she was able to do was identify tumor nests on these pathology images, identify the strands of collagen, and then essentially assign a vector depicting the orientation or the arrangement of these individual collagen fibers. And essentially, what we were able to show is that when you looked at the relative order or disorder of the collagen, it was dramatically different between patients who had worse prognosis, that is short-term survival, where there was more coherence with regard to the collagen, versus patients where they tended to have more disorder with regard to the collagen, and these patients were the ones who tended to have much better outcome. So initially, this was very counterintuitive. You would have expected the opposite to be true, but it actually makes sense when you recognize the fact that collagen has been implicated in metastasis of a number of these tumors. And so if you think about it, the more ordered the collagen, the more likely the tumor is to progress from the primary site to metastatic sites. Conversely, if you think about the more disordered the collagen, the more likely these tumors are to not progress, and therefore better outcome, better survival. And so one of the things we did in this paper from a few years ago was to first demonstrate on the TCGA that this collagen feature, just the entropy feature associated with collagen architecture, was associated with outcome. But we were able to validate this on ECOG 2197, a clinical trial that Dr. Badve was actually involved in as well. And so we were able to demonstrate on this retrospective cooperative group clinical trial that this simple feature actually was prognostic of survival, was prognostic of outcome. Last year, we followed this initial study with a subsequent study where we specifically went after the Oncotype DX categories. So we looked at the low Oncotype DX and the high Oncotype DX categories. So the left panel is the low, the right panel is the high Oncotype DX category. And again, from Dr. Kalinsky's presentation, we'll recall that if you had a low Oncotype, essentially it means you have good prognosis, good outcome, meaning you don't need the chemotherapy. Conversely, if you have a high Oncotype score, it means that you probably do need the chemotherapy, according to the molecular test. We decided to look specifically at those populations. When we looked at patients with a low Oncotype score, we found that the image classifier was able to stratify patients with a low Oncotype into a distinctive high-risk group and a low-risk group. So even though Oncotype was saying that all these patients in the low group should not be getting chemotherapy, we were able to identify with the image classifier 12% of patients who, even though they had a low Oncotype, in hindsight should probably have benefited from chemotherapy because they had a significantly more aggressive phenotype or risk profile. Conversely, when you looked at patients with a high Oncotype, again, where Oncotype is saying that all these patients should be getting chemotherapy, we were able to identify something like 57% of patients with the image classifier who had a significantly lower risk profile, less aggressive risk profile, suggesting that possibly in hindsight, these patients could have avoided the chemotherapy. But this has to be validated. And I think you heard from Dr. Kalinsky that one of the things that our group's been trying to do has been to validate these signatures on completed retrospective clinical trial datasets. And that's a big advantage of computational pathology, is that these clinical trials have been done. ECOG 2197, which I talked about, was done back in the 90s. And so those slides that we were able to pull together and image were from 30 years ago, right? But we were able to sort of resuscitate these older trials. And by leveraging the power of AI, we're able to go back and look at patients treated over 30 years ago. This is the SWOG study that Dr. Kalinsky referred to, SWOG S8814, where we demonstrated that the signature was associated with overall survival. And we worked with the SWOG group to publish this data at the San Antonio Breast Cancer meeting a couple of years ago. This is work that with Dr. Badve and colleagues in the UK that should be coming out either this week or next week in Lancet Digital Health, where we looked at DCIS. DCIS, or ductal carcinoma in situ, which is a pre-invasive breast cancer phenotype. And the big question in DCIS is, should these patients be getting radiation therapy? Should they get surgery alone, or should they get surgery and radiation therapy? And what we've shown here is that using AI to look at the immune infiltrate on the digital images of DCIS, we were not only able to predict which of these pre-invasive DCIS patients were going to progress onto invasive full-blown breast cancer, but critically, we were able to demonstrate that we could identify which patients were truly going to benefit from radiation therapy, right? And again, the reason we were able to do that was because we worked with Dr. Thorat in the UK to leverage the UK ANZ clinical trial, a completed clinical trial where patients with DCIs have been randomized to different treatment options. And so leveraging this completed clinical trial from the UK, we were able to validate this signature as not just prognostic, but predictive of benefit of radiation therapy. Just give a couple of other examples. This is work in GU cancers and prostate cancer, where we demonstrated a few years ago that looking at more explainable features relating to the shape and the arrangement of glands from pathology images, that we were able to predict the risk of biochemical recurrence in a cohort of almost 1,000 patients, 1,000 men with prostate cancer from multiple different sites, looking just at the shape of the individual glands, but also the spatial architecture and the spatial arrangement of glands from H&E images of their surgical specimens. Like the Oncotype DX in breast cancer, there is a $3,000 test called the Decipher test in the context of prostate cancer. This again is used to identify which men will have metastasis after surgery versus not. And we went head to head with the Decipher test. Again, that's a molecular-based test. And when we went head to head with the Decipher test, we actually were able to show that the AI-based test on the pathology images was actually equivalent and non-inferior to the Decipher test. But the key finding in this study was the fact that when you actually combined the image features with PSA, preoperative specific, prostate-specific antigen, as well as the Gleason score, we actually got a hazard ratio that was almost double that of the Decipher test, meaning that simple image predictor, along with a couple of different clinical variables, outperformed this $3,000 molecular test. And you could do this potentially for pennies on the dollar compared to some of these molecular-based tests. But more than that, this is work from Dr. Kamal Hamouda, who's a postdoc in the group, who's recently shown that if you look at the Decipher low patients, so I talked about the Oncotype low for breast cancer, in prostate cancer, Decipher low, these are men who typically will have less aggressive prostate cancer, less likely to have metastasis. What you're finding here is when you looked at patients with Decipher low, almost half, in fact, more than half of the patients are being identified by the image classifier as having far significant worse outcome. So significantly greater risk, suggesting that these patients actually should be candidates for additional therapy. And so adding more granularity, adding more discriminability over and above this molecular-based test. This is some unpublished data that I want to share. This is from Sebastian, Naoto, and Kamal in the group. Sebastian standing out there at the back. Working with the RTOG or the NRG group, we've been able to analyze patients from 0521. This was a clinical trial that was completed several years ago where patients with prostate cancer were randomized to docetaxel or not. All the patients got androgen deprivation therapy followed by radiation therapy. I see Dr. Jani is out here, radiation oncologist for prostate in the first row. So these patients got ADT radiation therapy and they were randomized to docetaxel, which is chemotherapy. And what we were able to do working with NRG is to analyze, to get the slide images from that study. We analyzed with our AI algorithms, looking at the immune architecture on these pathology images, and actually showed, and this is unpublished yet, but wanted to share it with all of you. There's a lot of data here, but let me just break it down. Basically, we were able to show that when you looked at patients who got ADT plus radiation alone, that is no chemotherapy, we were clearly able to distinguish between a high-risk group and a low-risk group. Conversely, when you looked at the docetaxel arm, there really was no difference between the two groups, meaning that our assay was not just prognostic, but actually predictive for added benefit of docetaxel. So this is really critical because the big question in these patients is, which of these men is truly going to benefit from chemotherapy over and above the androgen deprivation and the radiation therapy. And so this is really exciting because here we've used a clinical trial again to validate that the assay is not just prognostic, but actually predictive for benefit of chemotherapy, meaning that you now start to get to clinical actionability. All right. So just in the interest of time, I'll sort of skip over some of this. I just want to share, since we talked about immunotherapy with Dr. Kalinsky's talk, I just want to share a couple of slides here and some of the work we've done with immunotherapy. These are lung cancer images of patients that have been treated with immunotherapy. we looked at their immune architecture and looked at the spatial architecture, spatial arrangement of the immune cells from baseline biopsies and showed that we could predict response to immunotherapy in these patients, but critically, we're also able to predict longer-term survival and outcome in patients treated with different immunotherapy drugs. But perhaps the most interesting observation in this paper from a couple of years ago was this piece of data where we showed that in patients with low PD-L1, so PD-L1 is the biomarker that's used to identify which patients are going to benefit from immunotherapy. And if you have low PD-L1, essentially it means that you're likely not going to benefit from immunotherapy alone. So these patients either are not candidates for immunotherapy or they get combination of immunotherapy and chemotherapy. But what was interesting here was when we looked at patients with low PD-L1, the AI classifier was able to identify a subset of patients, this is in the yellow curve, patients who actually were going to have good outcome, good favorable prognosis, meaning that those were patients who potentially could be prioritized for mono IO therapy and could forego the chemotherapy. All right. And this has now been validated with our colleagues at BMS on a completed clinical trial, Checkmate 057. And this was published, Chris Barrera, I think, might be in the room. Chris is a graduate student, and Chris showed in a very nice paper last year that this signature was also associated with outcome in this completed clinical trial. So, all right, with that, hopefully I've conveyed the point that computational analytics with routine pathology can potentially address questions in precision medicine, specifically around prognosis and predicting response to therapy. Completed clinical trials really represent a magnificent resource that have to be exploited for both radiology and pathology images. As we talk about our AI algorithms, we really should be leveraging these completed clinical trials to validate these assays, not just as prognostic, but as predictive of benefit of therapies. And let's not forget the affordability aspect. We're privileged to live in the United States. My own native country of India, like I mentioned, is still a low middle income country, doesn't really have the kind of resources that we may be able to avail of here in the US. And so as we think about AI, we have to think about equitable AI. We have to think about approaches that are going to benefit not just the US, Europe, but really the entire planet. And of course, we have to think about equity. I didn't talk about some of the work we're doing around this topic, but we have to be intentional and make sure that these AI technologies truly work across diverse populations. And with that, I just want to thank the real superstars, number of folks in the room who are from the lab, students, postdocs, scientists, too many to mention, but a number of them are here in the room. They're the ones who do all the heavy lifting. And of course, thanks to the funding agencies that put food on the table. Thank you. Take a couple of questions. Yeah. So I know my trainees are too scared to ask questions, so maybe someone else, yeah.
Great talk. But what do you see as the biggest challenge of exploring AI and integrating it into prospective trials? A lot of which you've shown is like validation of randomized trials, but looking at it retrospectively.
Yeah.
What is the biggest challenge of integrating it prospective?
Yeah. So, I mean, that was part of the reason for the question to Kevin is what is the pathway? And so, the pathway that at least we've been taking has been to continue to generate the data, to keep at it, to keep generating the data. We start with institutional validation, then multi-site institutional validation, then working with the cooperative groups or pharma to retrospectively validate. And then Dr. Patel is in the room, and hopefully Dr. Patel will talk about some of the work that we've started together, where some of the tools we've developed are now getting embedded prospectively as part of ongoing clinical trials. Hopefully Mihir will talk a little bit about some of the work we're doing in head and neck cancer, but I'll talk about one of the other studies that we have ongoing, which is with the Eastern Cooperative Oncology Group, or ECOG, EA5163, where we've managed to embed some of these tools as part of this ongoing clinical trial involving pembrolizumab for non-small cell lung cancer patients. And so last year, I think Pushkar is in the room. Pushkar Mutta is a grad student. He showed data at ESMO from this prospective clinical trial where we were able to validate these algorithms as part of this ongoing prospective study. And even though the study won't actually read out till 2027, we were able to demonstrate that there was a strong association between these AI tools and change in tumor volume. And so I think part of it is first, validation at an institutional level, validation on completed clinical trials, and then prospective observational data that sets the stage potentially for the highest level of evidence, which is obviously a prospective RCT. Right? Yes.
Are you running your loads in the cloud or running them locally?
Yes, it's a great question. So what we are trying to do is a lot of the development of the algorithms happens locally, and a lot of the initial evaluation testing happens locally on prem. But once we lock down our classifier, lock down our predictor, then typically we go to the cloud. What is also happening, and I'm sure this topic will come up today, is in this age of where you have regulations and there's a lot of security concerns and other concerns about data sharing, this concept of federated learning is becoming more and more common. One of the things that we found now with our partners is they want to work with us, but they're not going to share the data. So what we've got to figure out is how do we Dockerize, containerize our code so that the code goes to the data as opposed to the data coming to the code. And that's why all my trainees, we've got to containerize, Dockerize your code. Stop writing code in MATLAB. All right. Thank you very much.
All right, so next up, just before break, we have Dr. Ashesh Jani, who's a professor in the Department of Radiation Oncology and the James C. Kennedy Professor in Prostate Cancer at the Winship.
Thank you. It's a pleasure to be here. I wanted to thank Dr. Madabhushi and the entire Empathic AI for Health Institute for the kind invitation to speak here. I'm going to be speaking from the vantage of an end user. I'm not remotely an AI expert, but I want to be able to try to incorporate some of the exciting work you're doing into clinical trial design. I think prostate cancer radiotherapy is the real opportunity to do that. This is an outline for my talk here. I'm going to talk for a little bit about just some background and history. And then I'm going to go into what may seem like an eternity to some of you with respect to prostate cancer imaging, particularly PET imaging and how it relates to prostate cancer. I'll build up to some of the advances in pathology, and then I hope to try to tie it all together with some ideas for future directions. So this is an article I wrote with Sam Hellman over 20 years ago in Lancet. This was a review article that tried to do a lot of what we're trying to do now with basically to design an algorithm for management of localized prostate cancer. A lot of it is irrelevant now, obviously, it's 20 years ago, but I think the heart of what we're trying to do in terms of establishing the most accurate diagnosis possible, and then doing the most relevant and accurate staging workup to identify exactly what type of disease we're dealing with before we optimize the management of the patients. I think a lot of that is still the current challenge, and is I think one of the main themes of this current symposium. Fast forward now to 2024. This is the current risk stratification system for prostate cancer, going from very low all the way to very high. And as many of you know, at the core of it is the grade group, which is based on Gleason score, also T-stage and PSA. But you can see, very clearly how having the most precise diagnosis can help you to optimize the treatment. I'm going to return to this slide and some expansions of it in the later part of the talk. But for a while, I'm going to talk about imaging and oncology. Imaging has a ubiquitous role in terms of diagnosis, in terms of biopsy, staging, in terms of treatment decisions. For a lot of what we do in radiation oncology, treatment planning, treatment delivery, and then follow-up and response assessment. Standard imaging for initial management of prostate cancer was historically CT scan, bone scan, MRI scan. More recently, PET has made a footprint there, and also for recurrent prostate cancer, either post-prostatectomy or intact prostate. There's a lot of standard and novel imaging tests that can be done. MRI, of course, has a ubiquitous role, multiparametric MRI in biopsy staging, active surveillance, treatment planning, and treatment delivery. This is some prior work we did with Cytogen, which is radioimmunoscintigraphy. This is a study that had relatively, this is a SPECT study that had relatively, it didn't pan out. I'm not going to go into this in too much detail, but it didn't pan out because it had relatively low sensitivity, low specificity. It was a SPECT scan. It targeted the intracellular prostate-specific membrane antigen target. And it wasn't really until we got into PET imaging, which is the newest way of imaging prostate cancer, that we really made a dent in some of these algorithms. Now, many other disease sites, lung, breast, et cetera, were early adopters in PET because your common run-of-the-mill FDG radio tracer uptakes very highly. Prostate cancer and some others were later in latecomers to the PET dance, but this is an evolution of the molecular imaging for prostate cancer. There was Prostasyn back in '99, which I told you about, and it wasn't until C11 choline at Mayo 2012, and then invented right here at Emory and out of Dr. Mark Goodman's laboratory was flucyclovine, or FACBC, which is an amino acid analog. That was FDA approved in 2016. I'm going to show you some data on clinical trials that we've run using flucyclovine. And then most recently, there's PSMA radio tracers, which I'll go into in a little bit. But this is a randomized controlled trial that we ran. This is the Empire 1 trial. Empire stands for Emory Molecular Prostate Imaging for Radiotherapy Enhancement. This is an R01 funded study. Myself and Dr. David Schuster in nuclear medicine were co-PIs. And at its heart, it was a randomized controlled trial for post-prostatectomy prostate cancer, stratified by pathologic risk factors, PSA level, androgen deprivation intent, and it randomized patients to radiotherapy planning based on standard imaging versus molecular imaging. On arm B, there was one additional stop in nuclear medicine where the patient had a flucyclovine or FACBC scan done. Within arm B, we could compare pre and post PET decision-making and target volumes. But across arms 1 or between arms A and B, we could analyze cancer control outcomes. Now, the NCI really loved this design. At the time, there were a number of radio tracers being developed. A lot of the studies, a lot of the proposals that were coming into NCI stopped with sensitivity and specificity analyses. They liked this design because it integrated PET into treatment decision-making. The clinical decisions were hardwired based on the PET uptake. So in particular, if there was extra pelvic uptake, we aborted the decision to give radiation. There's pelvic nodal uptake, we treated the prostate bed and the pelvis. If there's prostate bed only uptake, we treated just the prostate bed. If there was no uptake, the de facto plan was to treat just the prostate bed. This is a trial that we reported in the Lancet a few years ago. This slide shows you the 3 major categories of decision changes that could happen based on the PET information. On the top is a gentleman who originally was going to get radiation, but then had a PET scan that showed, in this case, retroperitoneal nodal uptake and had his radiation aborted. That's one major class of decisions. Second patient here, the original plan was to treat the prostate bed, and he had uptake, in this case, in an iliac lymph node. And the post-PET decision was to expand the volume, not to treat just the prostate bed, but also to treat the lymph nodes. And then conversely, the gentleman on the bottom here, the original plan based on his having a high PSA and PSA trajectory was to treat the prostate bed and the lymph nodes, but his PET scan showed uptake in only the prostate bed. So the fields were reduced to just the prostate bed alone. Without going into too much detail, we analyzed these decision changes, and overall, the different categories of decision changes were all highly significant based on the PET uptake. We did a little bit more in this trial as well. We integrated the PET information into actual treatment planning and treatment delivery. So we were able to register the PET information with the planning CT scan and to identify areas that, or change the treatment volume, I should say, based on where the PET was uptaking. There is a semi-automatic algorithm now for doing this, for registering and for region growing and for identifying the areas of PET uptake. And this is a slide. This is a waterfall plot that shows maximum surface distance. Basically, if you look on here, it shows every spike you see here measures the distance between a volume that would have been treated without PET information and volume that was treated with PET information. You can see visually over the roughly first half of the patients that were enrolled, there's a significant difference, impact of using PET. But the proof was really in the pudding here in terms of doing a failure analysis. Using a standard definition of post-prostatectomy failure, we generated Kaplan-Meier curves, and a primary endpoint was failure at 3 years. And I want to stop here for a second and point out that this is a very high bar for an imaging test. Most imaging tests, even the ones that you use currently in practice, the bone scan, X-ray, CT scans, many of them have not been held to this high level of standard to see if it actually influences a cancer control outcome. So it was ambitious for us to look at this, and our hypothesis that the PET scan could do this was that we were not radiating patients that had extrapelvic disease and more carefully selecting patients, but then B, we were also integrating this PET information, making better treatment decisions and integrating it into the treatment planning process and coming up with better radiation plans. So we hypothesized a roughly 20% difference. And this is the punchline. This is the 3-year failure-free survival result that we saw. In the arm that didn't get the PET, there were 27 failures. In the arm that did get the PET, there were 15 failures. With the median follow-up of 3.5 years, we saw roughly the 20% difference in failure-free survival that we had hypothesized. And this was carried out to seen at 4 years as well. So this was an exciting project. It brought a lot of concepts together. And the more recent PET radio tracer is PSMA. This is type 2 transmembrane glycoprotein. The Prostascent work I told you before was targeting this sort of wimpy intracellular target, but the newer generation PSMA-rich radio tracers are targeting the extracellular domain. Without going into too much detail on the PSMA, there's basically a whole family of PET radio tracers. There's the gallium PSMA that came out of the UCSF and UCLA groups. There's the DCF-PYL compound that came out of basically Memorial and was evaluated in the Condor study. And then this RH-PSMA, which is radio hybrid PSMA, which allows for both diagnostic and it can also be tagged with radioligand for therapy. This is something we at Emory were one of the higher accruing sites for this, but this gives you a feel for what the overall sort of patient level detection, sensitivity, specificity rates are. So PSMA PET has really transformed what we do in terms of staging workup, both in the initial and the recurrent setting. This is an ongoing study we have. This is the sort of the follow-up for Empire 1. This is Empire 2, which picks up where Empire 1 left off. We're randomizing now flucyclovine, which was the experimental arm in Empire 1, now to gallium PSMA. This was a 5-year, also an R01 funded study with myself and Dr. Schuster being co-PIs. We recently, roughly a year ago, completed the 140 subjects that we needed to enroll on this study. The design is very similar with the exception that we are boosting sites to PET uptake to higher doses, to the dose ranges that you see here. Primary hypothesis is actually not a formal comparison between these two arms, but to see whether either arm can achieve an improvement in failure-free survival over the experimental arm of Empire 1. So stay tuned for the results on this. Just a couple of words about theranostics. I told you that PSMA can be used not only for diagnosis, but also for tagging with radioligand therapy. There's a number of studies used analogous to what's done for systemic therapy. We start with the most aggressive metastatic population and then work our way backwards to more clinically localized primary disease. I and Dr. Schuster have a phase 1 trial where we're evaluating a radioligand therapy. This is a very small Winship Dunwoody funded study that we are evaluating mainly a toxicity endpoint. 3 patients who get 1 cycle, and then if all goes well, they'll get a second cohort with 2 cycles. And we hope that this will lead to a larger project, hopefully Empire 3. So now, with all that in mind, I want to turn our attention now to prostate cancer pathology. I promised I was going to return to this slide. This is the NCCN risk stratification as it currently stands in 2024. Now, there's been a number of efforts to develop nomograms based on selected clinical variables and models. You can see them all listed here for localized. Recursively, NCCN lists their own, as a risk stratification, but there's CAPRA and MSKCC and et cetera. For localized post-prostatectomy, there's CAPRA, biochemical recurrence, there's a few, and then for metastatic. Most of these are predictive. Most of these are prognostic, and just a few of them are predictive. In terms of genomic expression, these are the commercially available ones. GPS, which is a 17-gene genomic prostate score. Prolaris is 31-gene cell cycle progression assay. Decipher, which Dr. Madabhushi went over, is a 22-gene genomic classifier. Decipher is being integrated prospectively into some of our energy oncology trials. In particular, there's 2 trials, Energy GU009 for high-risk prostate cancer, that's looking at low decipher scores and stratifying by 24 months versus 12 months of hormone therapy. And in the high decipher, 24 months is considered the standard, but they want to randomize to 24 months plus apalutamide. And then analogously, there's a sister study, GU010, in the unfavorable intermediate risk space that is stratifying by decipher, and then low decipher patients get either 6 months versus no hormone therapy, or in the high score, get 6 months versus 6 months plus darolutamide. So these are active studies. We're actively enrolling. We're one of the higher accruing sites to both of these studies. Many of you know that there's a lot of development in prostate cancer pathology AI. There is the one example is this multimodal artificial intelligence, Artera AI algorithm that was developed using data from multiple large randomized phase 3 clinical trials that were RTOG. They took clinical data and biopsy tissue. They digitized biopsy tissue slide image data. And what you can do now, this is available commercially, is you can take an individual patient, send it, send out the slides, they can digitize it, and they produce a prognostic score that gives you the risk of METs, risk of death from prostate cancer, and then for the intermediate risk population, a predictive score, basically the benefit of short-term androgen deprivation to radiation. This is sort of the clinical development of Artera. There's been several publications and presentations in this space here that I'm not going to go over in detail. So this is the end. I mean, all of this has worked its way into the NCCN principles of risk stratification now. So, you can see the Decipher, the GPS, the Prolaris, Artera AI, they've all worked their way into NCCN. They're expensive, as Dr. Madabhushi pointed out. You could also point to the fact that many of these were developed on retrospective data sets and not studied prospectively, but nonetheless, they are available commercially. And with that, I just wanted to spend a few minutes on what I think some of the key open questions are. Oh, 3 minutes. I'm almost done here. So this is, again, the title of my talk was Radiogenomic Model. I should have said radiogenomic model works in progress because what we're trying to do with Empire 2, we do have an exploratory aim where we are using the PET information and the Decipher to develop a radiogenomic model, basically seeing how Decipher, whether it correlates with PET or complements it. One thing I can share with you, which was not successful, Energy GU009 originally was supposed to be analogous to Empire 1. It's supposed to be an imaging study, but then got morphed to a biomarker study studying Decipher, and we tried to integrate imaging into that study. We were not able to do that successfully because the imaging needed to be blinded, and if it didn't, it was going to interact with the primary endpoint. So that is one challenge to doing a study that both looks at Decipher or biomarkers and imaging. And then just I'll mention in passing, we have an ongoing effort to do in the post-prostatectomy setting to develop a radiogenomic model that may get folded into a prostate spore project and possibly an R21. I think there's a lot of areas where I think AI can help us in the radiotherapy GU arena with advances in imaging, advances in pathology, advances in radiogenomic model development. I didn't talk too much about this, but specific within radiation oncology, there are AI-based contouring and treatment planning. Xiaofeng Yang in our department does a lot of work in this area and ultimately will help with treatment delivery. And I'd like to see a lot of this integrated into clinical trials. Clinical trials, I've spent the last decade or two, working in the clinical trial arena. It'd be nice not to have to run like 150 patient prospective trial, for every clinical question we want to answer. So being able to use AI to at least get signals on some of these questions before they're tested prospectively would be welcome. And I think that, I'll stop here. Basically, as you can see, it's an exciting time to be in imaging and pathology. I think a lot of these studies are having impacts on prostate cancer management outcomes, and I think the best is yet to come. So thank you for your attention. Any questions? Yeah.
Right. So, it's a great talk, Ashesh. So, I just wondered whether you could speak to Depa AI, and specifically with regard to the NCCN guidelines, because when I saw that just blew my mind. The test that had 2 publications,
Yeah.
and a bunch of presentations at conferences could make it into the NCCN guidelines, based on retrospective analysis where they pooled 5 different NRG trials and then combined all of those, took 80% for training and then hold out 20% for validation without having an independent clinical trial that was set aside for validation.
Right.
Just trying to understand, like, what am I missing here? Because it seems to me like, how did it get into the NCCN guidelines?
I mean, you're spot on. I mean, I think, there's a lot of momentum and excitement in this area. I think that may have something to do with people are eager to use this. Our AI is going to be studied prospectively in the next, the concept that's in development within NRG. NCCN is, depending on which meeting you're at, it's basically, 5 people on a teleconference making these decisions. So it's not, I don't want to say it's political, but it's political, some of it. So there's a lot of factors that go into it, but nonetheless, that's where we are right now. Yeah. All right, thank you.
All right, my apologies for letting us get a little bit off schedule. We're scheduled for a break right now to end at 2:40. That's 4 minutes from now. To be sensitive to everyone else's schedules, we'll try to start right at 2:40. So please take a quick little break. Thank you. All right. Good afternoon again, everyone. Are we sharing? Yes, we are unmuted. Okay, hello, everyone. Again, welcome back from the longer than expected break. I apologize again for letting us get off track. All right, so to start off our after break talks, we have Dr. Mihir Patel, who's a professor in the Department of Otolaryngology, where he serves as chief of the Division of Head and Neck. He's also co-chair of the Head and Neck Working Group at Winship.
Thanks for having me. Really honored to be here. I think that the idea, a lot of this is just really going to be about questions I have and things that we can do to try and move oncology forward. And so I'm going to go through this rather quickly. There's a lot of little vignettes and kind of highlighting things that we're kind of doing and things that I would love to see happen in ways that will, again, revolutionize what we're doing. And so it all starts with what we do from a head and neck program standpoint. It's just a general overview of the impact head and neck has in the general community in Georgia, and particularly on our healthcare system at Emory. We demand a number of resources. Our patients require tremendous amount of support in so many levels. And to organize all that is a huge operational lift. And so if you look at the number of providers that are involved, it really demands a tremendous amount of coordination. And even looking at, from a surgical case, if you look at the number of frozen sections we do a lot more than what's typical in the entire system. And that's because of the way that most of what we see is squamous cell cancer occurring on the surface. You have to really look at all the edges. And so that requires a lot of throughput analysis, where you can imagine that things like what Dr. Madabhushi is doing could potentially revolutionize how we look at slides in real time on frozen section. And so this is an example of things that we input manually. When we see a new patient, how long does it take? What's our access? And the reason I bring this up is we're working right now with our Emory technology team to look at a proposal of how do we actually optimize throughput? How do we communicate throughput on all levels, from the cancer center, from working groups, from all those providers I just showed you before, from the peri-op operations team in the hospital, from anesthesia, from pathology. All of those things can get wrapped up into this one single dashboard that really just needs a little time. So this is real future, doable, probably with just, a little bit of time and project. So this is just an example of what you can accommodate or accomplish in an hour. An hour of work to create a Power BI schedule where you can see all of these metrics. How long does it take to get your infusion started from first time of visit? So time to treatment. How long does it take to go from surgery to adjuvant therapy? Are we meeting the windows of 6 weeks, which is the defined timeline in head and neck, to optimize survival? All of these things. Does the preoperative patient have their scans? Do they have their imaging? Do they have their pre-custom made plate that we need to reconstruct their jaw? This throughput can be seen in a longitudinal way. And so we're excited about what I feel like is near future. So this is just, really the overview is the benefit statement at the top, right? This is the way I think about it. And I hope you all will think about this as opportunities. But what I want to look at is maybe how far in the future can we go and what can we do? So this is an oral cavity specimen. Again, we're working in collaboration with the Madabhushi lab with looking at oral cavity specimens. How can we look at them in a way where, one, we know where to make the cuts? So this, on a normal day, let's say 10 years ago, even today by NCCN guidelines, is considered unresectable, T4B disease. And we've shown here at our center that we can get 50% 2-year disease-free survival. And I think a lot of that has to do with how we actually have optimized care, how we, again, can reconstruct something like this. Number one, that's the first thing. Is it going to be functional? Can you reconstruct it? That we can do. Number two is, can you get clear margins? This is kind of what it looks like in a slide once it's formalin fixed. You can see where tumor is. We can't see that while we're operating. So it would be amazing to see if there's a way that we can optimize the cuts we make so we minimize extra tissue that we take. In this situation, you just kind of have to go big, for lack of a better word. And then you check it on pathology, but they can't cross-section all of these things at frozen section. They cross-section what grossly looks like the closest thing. And then we take and hope that that's going to be a clear margin at the end of the day. But you can see, if you can imagine, that if we can incorporate AI and pathology into frozen sections, that we can really enhance accuracy of oncologic margins, and then potentially use these opportunities to even incorporate targetable mutations or things of that nature within our pathology read, even at frozen section, to help optimize these outcomes and patient survival. And so this is just over the past 5 years at our multidisciplinary clinic, this is our actual data. So this is our survival data. And if you compare it to, databases that exist and optimal outcomes, we're doing pretty well. And given the high acuity of the disease we see for stage 4, we're actually doing a little bit better than most. But again, this involves a tremendous amount of work on our pathology colleagues. So now we're going to transition to a different disease, HPV-related oropharynx cancers, where there's, again, another opportunity to potentially try and figure out what's going on with what we call unknown primaries. So unknown primaries are patients often show up with a neck mass. They show up to our clinic and we use PET scans. We do algorithms. We try and find out where it is. And we don't always know where it is. And I'll show you an example specifically. But what's even more important to think about is that when we try and stratify these patients for treatment, it's extremely challenging because are they going to go to surgery? Where are you going to operate? Are they going to go to chemoradiation? Where are you going to direct your radiation volumes? For an early stage primary cancer, you're going to potentially radiate the entire oropharynx, which is a large part of the mouth, which in our younger patients that typically have something like this, they're in their mid-50s, early 60s. That's potentially 20 years of downstream ramifications of treatment. In a meta-analysis, what we've seen is most of the time when we go hunt for these things, it's on the ipsilateral side. So this paper changed how I look at things and where I operate. And I'll take you through a case. So these are the numbers for when we do something to evaluate where this new primary is. So if they have a lymph node, we think it's HPV clinically. This is what cancer looks like on FNA. Is there an opportunity here to say, okay, we 100% know it's HPV? Right now, we have to look at our clinical picture, say, okay, they're not a smoker, probably the case. Oh, they're younger, probably the case. And we follow these demographic guidelines. And so if you have enough cells to stain for P16, which is only a surrogate marker, it's not ideal. It doesn't tell us if there's HPV DNA, and it doesn't tell us if it's HPV in situ. We're still, again, a little bit guessing. CT offers a 23% chance of finding the primary. Adding a PET increases a little bit. And then if we have to take them to the operating room for a biopsy to try and to even get to 56%. I mean, if you say the 56% chance of accomplishing anything, it's really not, that ideal. So what we've incorporated is what we call our towards unknown primary protocol, where we take them to robotic surgery. Again, not ideal, but it does minimize treatment effect potentially. And so what we do is we start off with a tonsillectomy, essentially what anyone would get for a sore throat, kids, things like that. And we send it to pathology for frozen section. Can you imagine being the pathologist that day having to evaluate this frozen section, looking for potentially a 3-millimeter tumor in this section? That's if we get the cross section. And that is if, when you put the tissue on the frozen cutting guide, how much tissue are you losing? Are you losing that tumor within the cuts as you're doing your frozen section? And so we pick a couple sections. Usually I rely on one of the PAs to pick it. They're usually better than me at it. And this is just an example of what the carcinoma would look like. And again, these are our margins. We would be fine. We would be clear and we'd say, okay, look, we found it. You don't need radiation to the primary site. But this is what happens if we don't find it. We actually have to go then take some of the tissue off the tongue base. The lingual tonsil adds morbidity. There's very clear evidence that this does change your swallow and potentially some of your taste long-term. But what else are you going to do? This is a case that we did. This was a 2-millimeter tumor that was not disclosed at frozen section, but found subsequently after P16 staining was done. So I told the patient, look, I didn't see the tumor on frozen section. I'm sorry. We'll have to wait for final pathology. And, thankfully it was found, and it gives them some comfort. From a survival standpoint, even if it wasn't found, I know that they're probably going to do okay, but they don't know that. And no matter how much you tell them that, you're not going to convince them of that. And so, again, this is just another case where we have these situations, and I'm just going to kind of go through the PET scan quickly. One of the tools we've incorporated is using green, blue light, NBI. It's used in the GI. I thought, oh, maybe we can try it in the head and neck. And you can see a small ulceration here. This is where the cancer is. Okay, and I'll just show you what it looks like on pathology when we took this NBI treated, directed lingual tonsillectomy. But now one of the things that we have to add to our diagnostic algorithm is molecular biopsies through ctDNA. So liquid biopsies are helping with HPV specifically, but this technology is expanding dramatically. And I think this is where there's opportunity for potential synergy with AI, molecular targeted or ctDNA, let's call them stratification factors for clinical trials, because I think that is the next level. So this patient had an elevated ctDNA HPV. We took out the tumor that you can see there that correlated with that little ulcer I showed you in the scope exam. Here's what it looks like on H&E sectioning. We were expecting this a little bit because of that. But it would be great if there was a way to know that this is where I needed to go based on a more, something that's not so dependent on the user. And so his ctDNA level went down to not detectable. And in that situation, we have the opportunity to reduce these volumes of radiation. All you need to know here is that the red is on where we spared the base of tongue here. You can see that there's just a lower dose. And on the other side, he had to get, that patient would have to get more. So we are sparing some tissue here. We're potentially improving quality of life and hopefully mitigating some of the downstream ramifications of treatment that is needed to cure, right? I'd much rather have 20 years of life being cured and have to deal with the downstream ramifications later than not. But if we can mitigate some of those things, it's a big deal. This is our trial. If a patient does have a ctDNA that goes to not detectable, this is what we do. So now we're even lowering the dose to a smaller amount, not only in volume, but in intensity. And so Dr. Bates is pioneering this trial. It's doing amazing. It's about to close. I would love to have a follow-up trial that incorporates some AI biomarker algorithms with this, and something that we could look forward to partner with in the future. This trial accrued in 18 months, 40 patients. So it's very quick. And this is what it looks like just from a functional standpoint, if you think about it from the patient perspective, or what we look at with the ctDNA specifically. Other people are doing this in terms of looking at ctDNA as a biomarker. I only show you that there's data out there to learn from, because here is data from Mayo looking at ctDNA, and it does depend on the test. There's no question about it. Some tests are better than others. But the point is data is there for learning. And again, this is just trying to risk stratify when would you have an elevated ctDNA. And the reason it matters is because maybe you need to intensify. Maybe we need to intensify treatment in those cases. And so this is our own data looking at those unknown primary cases I just showed you or alluded to, where we've looked at our patients to see which of those patients likely will have an elevated ctDNA. And from what we can tell, it's going to be because they have a lot of lymph nodes. Patient has a lot of lymph nodes, they probably don't need to go to surgery, and I would rather not operate on those patients, but they could be subclinical, they can be small, but in a patient that has more than 4 or 5 lymph nodes, we are not going to typically operate on those patients, and they're better served with chemoradiation therapy. And this is just kind of what this looks like. This data is available for anyone who, I'm happy to share this with you all and get this to you if that is of interest. So we're working on publishing this, but if you need the raw data, we have that. And again, just in the interest of time, this is just another example of what do we do in cases like this. And this is what we use to determine treatment. We look at the CT scan, we look at the picture, and we say, okay, what should we do? There's something called extranodal extension. I think I'm sure you all are aware of. If tumors are kind of going beyond their lymph nodes and breaking that capacity, it's very challenging to see this on HPV tumors. It's been published many times. Obviously, we're working on an algorithm to try and validate that and see if we can predict it, because then that is a fork in the road in terms of treatment and decision making, and it really does impact care. So, this is just, again, these are things that happen with ctDNA. What happens when it goes up? But you don't see a tumor on imaging. We take a PET scan, we don't see anything. This happened to a patient of ours that we operated on. And this is when ctDNA was first available. I didn't know what to do. I thought, oh, well, it's elevated. It's elevated multiple times. We know there's something there. What should I do? And this was one of the first cases, but I can just tell you that, in hindsight, I wouldn't have done what I did, but we wanted to be fastidious. We looked around. I took him for a biopsy, didn't find anything. I thought, oh, maybe it's on the other side because he didn't have radiation. Continue to be elevated. So he had morbidity from this. And then I did a neck dissection on the other side thinking, oh, well, maybe it's an unknown priming on the other side. The neck usually is the source of the increased ctDNA. And I know I did a fairly good neck dissection on the other side, on the first side. And lo and behold, we've taken him to all this stuff only to find that imaging finally later showed 2 nodes on the same side that I had first originally done the operation on. So he went through all this morbidity, all of this, angst, where it would have been great to have an opportunity to have some help with this. And we are incorporating some of this into lymphocytes, maybe potentially opportunities to look at how we can evaluate these lymphocytes at an individual level, and then maybe incorporate AI into this realm too. I think this is where it would be really beneficial to see how this could be done. Dr. Madabhushi referred to a clinical trial. I'll show you the scheme of the clinical trial very shortly, so that you can see what that looks like, in hopes that we can generate data to produce opportunities like this. And so in summary, I mentioned the operations. That's, I think, within reach within the next year, right? We know that that can be done. It's just a matter of time and input. But these other things, these are going to take some time to develop. And I think this is where there's real opportunity to incorporate this into what we do. This is the trial that was alluded to. And we are looking at preoperative PD-L1 therapy, taking scans. We're going to use those scans. Bolin's going to look at them, tell me whether there's E&E or whether the prognostics are good or bad for that patient. And hopefully we're going to have some data in the next year. Rafi is going to go look at the lymphocytes, characterize them in multiple ways, and hopefully we can take that pathologic information and biologic information and incorporate it in some type of algorithm that's going to be meaningful for whether it's vaccines, cure, other types of biomarkers, or whatever you might think of. But I think there are opportunities, most importantly, for creating what I'd like to call AI stratification factors in clinical trials that will drive meaningful results. That's all I got. Happy to answer any questions.
I just had a comment, maybe Drew can chime in. I know that Drew's former lab that in Boston, they've developed an algorithm for using AI to identify for these cups, for these cancer one primaries, trying to identify what the origin might be. Just wonder, is there an opportunity here to leverage that? Because that seems to be a real pain point for Dr. Patel.
Yeah, potentially. I mean, I think determining the origin within the or parents of where like an HPV positive squamous cell carcinoma would be is like 1 or 2 orders of magnitude more difficult than determining what other organ would become, just because the histology is so similar.
It's super challenging. Yes. It's super challenging. I mean, I look at these slides when their frozens are being evaluated and I look at it, first of all, I'm always amazed that, when they do find it, that they can. And I'll say most of the time they do, if it's there. I mean, or if we take the right section, but it is, it's extremely challenging. But we have lots of data. We have lots of slides.
The other point I'll just quickly make, because you talked about frozens and margin. So Monday is aware we are recruiting, just had a faculty member from UC Davis accept a position at Emory in pathology, Dr. Rizal Ferdouni joining us. And he's coming with some very exciting novel imaging technology, fast imaging, that will allow for fast real-time imaging of specimens, surgical specimens. And Sunil, myself, Rizal, soon should be able to share some good news about a grant that we're getting that's really focused on this problem.
Yeah.
We're not going to be looking, as part of this grant, we're not explicitly looking at head and neck. We're looking at breast and ovarian. But certainly, I think that we'll have the infrastructure set up for patient.
Yeah, no, that sounds exciting. Look forward to it.
Next up, we have Dr. Germán Corredor, who's assistant professor in the Wallace H. Coulter Department of Biomedical Engineering at Emory and Georgia Tech. Let me get that set up for you. All right, take it away. Oh, sorry. Also, the coffee has been delivered outside the auditorium. But don't leave this yet. Yes, the coffee is here.
Take a couple minutes break so that folks can get coffee.
Okay, sounds good.
Okay, so good afternoon. My name is Germán Corredor. Thank you for the invitation to this mini symposium on computational pathology. This is just like the agenda for today. And I think I can go through this very quickly. We have been talking the entire day about how computers can help us. And these are just some examples. We can do quantification and diagnostic support. We can do prognosis, and we can do prediction to treatment. And because this is a symposium on computational pathology, well, I wanted to mention that this is possible thank you to the digital pathology development that allowed us to go from glass slides to digital images that facilitate the analysis via computers. And this talk is specific for head and neck cancer. So actually in the lab, we have worked on different projects, but we have a special interest in head and neck because we have more cases every day. So it's a growing, it's growing in importance. And as Dr. Patel mentioned in the previous slide, in the previous presentation, there are many unmet needs on this disease. So in our lab, we have been working on developing different biomarkers, trying to address specific issues for different anatomical sites, for example, the ear cavity, the oropharynx, larynx, and of course, we are trying to extend these to other sites. So I want to start with some biomarkers based on cellular diversity and architecture. So this is work from it's going to be 10 years ago. So we were analyzing the nuclear features. More specifically, we were trying to capture variance in nuclear shape and texture. And we created these maps that allowed us to obtain metrics for identification of patients with oral cavity cancer that have better and worse prognosis. In a related approach, we were creating these funny looking structures that we call flocks that basically group nuclei that have similar features. And again, we were building these flocks and then extracting multiple features from these flocks, like the intersections and density of them and the length of them and so on. And we were trying to find the association between metrics derived from these flocks and automatic differentiation of HPV positive and HPV negative oropharyngeal cancer. So we found that these features that we extracted from the flocks were actually very good at identifying patients or like at separating patients from having HPV positive and HPV negative. And in combination with other features, in this specific case, core features are related to orientation of the nuclei, we were able to have an even more accurate classification. More recently, we started to work on quantification of multinucleations. So for non-pathologists, multinucleation is when we have a cell with multiple nuclei, and it's usually an indicator of an aggressive disease. So the baseline is if you have a lot of multinucleations, you have a more aggressive disease, and very likely you will have poorer prognosis. This is well known, but the problem is that identification and like counting the multinucleations by eye, by a pathologist, is time consuming and it's prone to error. So there is a lot of subjectivity in finding the multinucleations. So that's why this is not used in a standard way. So that's when we decided to use computational pathology. We were integrating artificial intelligence or machine learning with image analysis, trying to find automatically those multinucleations. So we create a deep learning architecture and we train the model using some annotations, and we found the nuclei, the multinucleation, and then we created or we computed something called the multinucleation index that computes like what's the total multinucleations per the total number of cells. And this metric was very useful for risk stratifying patients with HPV or oropharyngeal carcinoma. So we had a large data set of patients from multiple institutions, and then we applied our model based on quantification of multinucleation, and we were able to find that there are statistically significant differences between the high and low risk groups. In this case, patients with high and low multinucleation index. And when we applied these to different stages, we found that the multinucleation index was prognostic for stage 1 and also for stage 3. This is especially good when we talk about stage 1. I will explain that later. But we also check the multinucleation in the context of racial disparity. So we found that when we quantify multinucleations using the two different populations containing white and black patients, we found differences between these two groups. And this is very useful for the development of models that were across populations. So this is just like the first step to creating models that are like equitable for the population. More recently, we started to work on biomarkers based on quantification of tumor-infiltrating lymphocytes. So this is just how it works. So we have the images, and then using machine learning and image analysis, we were able to find nuclei there. And then using machine learning, we were able to find lymphocytes. This is very good because lymphocytes have been shown to be to have a prognostic value. The problem is that pathologists struggle to quantify them because it's always a lot of effort. It's prone to error. So this was very useful because we were able to find objectively where the lymphocytes are, and we can get metrics from them. But we decided to go beyond that. So we were asking, what if it's not about the quantity of the lymphocytes, but also about how they are organized? So that's why we tried to go beyond, and we created groups of cells, lymphocytes and non-lymphocytes. And then we created clusters of these cells. In this case, you see these polygons are just the clusters of lymphocytes and non-lymphocytes. And from these clusters, we extracted several features related to spatial organization, overlapping, abundance, neighborhood, and so on. Then we applied these to a set of cases of HPV positive oropharyngeal squamous cell carcinoma. And as I said before, multinucleation was prognostic for patients with stage 1. And in this case, we also were interested in patients with stage 1 and with who are light or non-smokers. So we consider like less than 10 packs per year is a light smoker. And we found this prognostic, and it's this is relevant because there is a lot of interest in de-escalating the treatment of patients with oropharyngeal carcinoma, specifically those with HPV positive. The problem is that a group of patients with this disease still develop recurrence. So it's not just like de-escalating all the patients. And with this approximation and also with the multinucleation, we were able to find those patients who actually benefit from this de-escalation. We extended the validation and the experimentation for this approach, and then we applied these to the clinical trials RTOG 0129 and 0522. And we found that the metrics based on the spatial organization of TILs and other surrounding cells was prognostic in this validation trial. This was a blind validation. We generated the results and we shared them with the team at RTOG. They ran the analysis and we got this curve. And this work is going to be presented at ASTRO this year. We extended this also to, so the previous work was on oropharyngeal cancer. This was applied, or a similar approach was applied for laryngeal squamous cell carcinoma, trying to find risk of regional recurrence. And again, this approach was prognostic. And we have extended this to oral cavity. This is actually work in progress. We are trying to gather more cases to carry out a more comprehensive validation. We are also in the process of validating this in the context of clinical trials. And finally, we have also applied this for prediction of immunotherapy with promising results. So this work was published back in 2021, but more recently we got access to more cases and we got better results. Unfortunately, I got the results just a few days ago, so I was not able to include them here. But the message is that the analysis of this spatial organization of TILs has a lot of potential for prognostication and also for predicting response to treatment. We also have some biomarkers based on collagen fibers. So you may look, this slide may look familiar for you. It was presented previously by Dr. Madabhushi. So this is work that initiated in the breast cancer space, where collagen fibers were like automatically segmented, and then the orientation was computed, and then metric based on the organization of this orientation was obtained. And this was initially for the breast cancer space, but we have moved this to the head and neck space, and we have run some experiments on the HPV positive oropharyngeal carcinoma with successful results. Similar for oral cavity squamous cell carcinoma. So we apply a similar approach, and we were able to find patients who differentiate between patients at high and low risk. And well, so we have more biomarkers on the way. So we have been working on integration of these biomarkers. So we are calling this community because it's like a community of biomarkers. In this case, we are integrating metrics from collagen fibers, from multinucleation, and from TILs, and some preliminary results on oropharyngeal squamous cell carcinoma is showing that the integration of these biomarkers is giving us a more prognostic value, like a better results compared to the biomarkers by themselves. And also we have other biomarkers in progress. So we are interested in tumor bindings, tumor-associated macrophages, some TIL subtypes like CD8, CD4, CD20, mitosis, neutrophils. So we are in the process of identifying these structures automatically and then extracting metrics that can complement the biomarkers that we had before. Some takeaways. So computational pathology has great potential for diagnosis, prognosis, predictive tasks. The biomarkers based on collagen fiber, multinucleation, and architecture of TILs have demonstrated great value for both prognostic, and we are moving to the predictive realm. So we are trying to demonstrate how they are for prediction. And the integration of the different biomarkers shows a synergy that we can use for creating more robust models. The next step will be integrating with genomics and radiomics, and we want to focus a lot more on developing models that work across populations. So that's it for this.
So it's a great talk, Herman. So I think the 800-pound gorilla in the room is you talk about all these biomarkers. Of course, we have Dr. Williamson here, who's been part of several papers now, high-profile papers in the last 6 months or so that are focused on these new AI models called foundation models. And so can you maybe speak to that? Like, what is your sense with regard to foundation models? I mean, should we, if I look at it from one viewpoint, should we even bother with these biomarkers and try to look at them when you have these powerful tools like foundation models? Hasn't that, won't that basically solve the problem for us? Just thoughts on that.
Well, that's a tricky question. So I think something that we have found in the lab is that the integration of deep learning models that are these black boxes that are hard to interpret with more handcrafted biomarkers is a good idea because it helps to understand what's going on there. So I believe that at some point there is a way that we can reconcile these and we could do like more like something pan-cancer or like these models that integrate both technologies, handcrafted, deep learning for better prognosis, better prediction. That's what I think. Okay, thank you.
So Anant, I'll try to answer your question.
But you're right here. So.
Okay, thanks. Okay, I'll talk a little bit about foundation models, very, very briefly, but we can chat about them after I'm done too. So I'm Drew. I pulled a little bit of an audible, very last minute here. Title of my talk originally was about histologic features, and we can talk about that a separate time, but serendipitous occasion occurred, so I switched it up. So I'm talking about chatting about pathology. And so, you know, if you're working with deep learning, or maybe even you know nothing about AI, a screen like this might be at least somewhat familiar to you. This is the ChatGPT sort of login screen that comes up when you open up ChatGPT. And I think, you know, people in pathology and outside of pathology and sort of every area of human life nowadays, people are getting excited about this sort of idea of having an AI that you can chat with. And, you know, medicine is not immune to that sort of hype. And we've seen publications like this one from folks at Dana-Farber, where they actually deployed a version of ChatGPT and GPT-4 at their cancer center, and were able to use it, as Emory is now doing with Copilot here, to sort of chat about the patient data that's there, maybe ask queries about the right way to care for patients, and get that sort of thing. And they have I love this picture from their preprint, just like what their chat GPT looks like at Dana-Farber. And in their preprint, that publication, and I'm not sure that Stat News is probably very happy with this, but they've reproduced this list of generative AI models that are being used now in healthcare. And this is just one of 3 pages of this table, but it's clear to me that there's not only a huge amount of interest and hype behind generative models like ChatGPT in medicine generally, but people are actually starting to use them. And I think we can have a very long discussion about whether that's wise or not, or what specific use cases that might be good. But to me, it's clear that people are doing this regardless of if it's a good idea or not. And there's been, in the past 6 months to a year, in the specific to pathology, there's been a number of publications about foundation models, including ones from my group, my postdoc group in Boston, coupling foundation models for vision and language together. And with the goal here being to come up with one foundation model that understands both natural language and pathology images. And each of these publications does things kind of a little bit differently, has different data sets they use to build this model. But at the end of the day, you train these models in some self-supervised fashion, and you get a model that can say, look at a pathology image and give you a caption, or given a query in natural language, maybe not produce a pathology image itself, but maybe search a database of pathology images that match closest to that query. And so again, in my postdoc group from Boston, we decided to build off of this idea. And the idea of a ChatGPT-like thing in pathology has been, I think, there's been a deluge of papers that are exploring, ChatGPT specifically for use in pathology, and I think there's no end in sight. And so, inspired by this interest and our work on vision language models, we set out to build a ChatGPT basically for pathology by pathologists. And here's the moment of serendipity. Our paper came out today in Nature. They were kind enough, or maybe crazy enough, to do a little accelerated version here. So this is like an unedited version that they put out. So not the final version, but you can go and take a look at it today, where we detailed this. Thank you. So I'll just talk a little bit about it. So, I won't go into the details of how the deep learning based stuff works here, but it built on 2 of our prior works in foundation models. So one is called Uni, up here in the top left, which was a pure vision foundation model. So that was trained in a self-supervised fashion, just using pathology images. This first version has 100 million pathology images. Those are individual smaller tiles from about 100,000 pathology whole slide images. And then we coupled that with our vision language model that was, again, built in a self-supervised fashion with vision and language, and, did this like magic recipe of combining those foundation models with some instructions. And we are inspired by an open source multimodal large language model called Lava from groups of folks at Microsoft. And, and basically we can talk about this more offline, built a ChatGPT, and I just want to show some examples from that. So the way we gather data for this, and this was like, I think maybe for any deep learning project, probably maybe all of science, is that, gathering the right data set is probably 80% or more of the effort and the pain and the tears that goes into something like this. And this was, pretty difficult. But we used a combination of educational resources. So those are like pathology textbooks. We, scraped PubMed articles. We got image captions from all sorts of places. We developed our own, data set to do this. And basically we developed this, 250,000 instructions that were sometimes only text, sometimes text and image. There were kind of questions and answers that we'd have this chatbot learn. And so some of these questions I think would be familiar to people that are like medical students learning about pathology, or pathologists, first year, second year, third year residents, et cetera. It might be the sort of question that you might get asked about a pathology image. And, these questions and these conversations that we built, span the gamut from like an open-ended response. So like, what do you see in this image? We had multiple choice questions, some were text only. And then maybe most important, we have this series of guardrails. And so this is from the preprint. Turns out we weren't able to use this meme image because it's copyrighted in the final paper. So, but I think very importantly, we had to bake into the training recipe here when we wanted the model not to respond to the query. And so, I think there's been some high profile instances. Most recently, I saw something from Google where Google's search version of Gemini is leaking the source code for Google. And I heard a story about engineers at Samsung who were using ChatGPT to help, proofread manuscripts. And it turns out the proprietary data for Samsung chips was getting leaked via that. And so putting in these guardrails in the training data set is super important. Once we had the model trained, we set out to evaluate it. And evaluating a model like this is incredibly difficult. And I could spend an hour talking about all the many, many pitfalls for something like this. But here's just some examples of the kind of conversations one can have with ChatGPT. We haven't been able to make it publicly available yet. But just some examples that I think are kind of relevant to pathology practice. And this was a common thing for me to get asked, and a point of stress, certainly at the beginning of my pathology residency, was I would plop down a slide under the microscope, be sitting across from the attending, and the attending would just ask me to describe what I saw. And thankfully now, maybe in the future, someone could turn to PathChat, as we're calling this model, to do that kind of captioning for us. And I think importantly for this sort of thing and for ChatGPT is that these conversations can be multi-turn. So it's not just, here's an image, what do you see, or a single question. PathChat actually has the capability to understand what you've asked it before in that conversation and respond based on that. And these are admittedly cherry-picked examples where the model is working very well and what we asked it to do. And so not all responses are like this, so many caveats here. And here's an example of a conversation that I could imagine being pretty clinically relevant, or being the sort of assistive tool that we imagine, a co-pilot, if you will, for pathologists, where maybe you're a pathologist in a low resource setting, or you're a trainee pathologist and you come across some tumor that you have no idea what it is, but it's a biopsy, a needle core biopsy of a lung tumor. And working with PathChat, because the training data set included things about immunohistochemistry, what tumors are positive and negative, and all that stuff kind of gets baked in. You can have this sort of conversation where you start with I have no idea what this is other than where it's from, and get some responses about what IHC you might order, and then work with here's what's positive, what's negative, et cetera, et cetera. And so I'll just play a couple, maybe only one or two of these examples of our version of PathChat 1 actually working. And I think this one has it's going slower than I expected. I don't know if I should vamp over the top of this, but it works. And there's video evidence of it. And in this training data set, because we use all kinds of medical data, PathChat understands not just the very pathology specific part of pathology, but you can also ask it, what molecular alterations are common for this tumor type, or things of that nature. And I'll just play one more example. And so, this is actually an image from a publication from a couple of years ago on cancers of unknown primary. And this was an example image that we used in the supplement for that paper. This is a real case that we had at Brigham and Women's Hospital, a patient with a lymph node metastasis. We had no idea where it's from. The tumor is very poorly differentiated. There's no way to know just from the H&E what it is, and the IHC is really confusing as well. And PathChat is able to help us make a diagnosis here.
That's going to pick the outcome for this patient.
Yeah, that's a very good question. All right, great. I'll stop it there. I'll skip this one in the interest of time. And so coming back to the evaluation here, evaluation for this sort of thing is super duper, really, really, really hard. one of the ways that we tackled sort of evaluation for this was curate a set of multiple choice questions that are kind of like a board style question that you might see if you're taking pathology boards, maybe with more answer choices than you would normally see. And, we compared PathChat against a couple other sort of similar chatbots. Lava and LavaMed are publicly available and we could run on our own servers. And then we used the GPT-4 vision and evaluated like, how does the models do on these multiple choice questions? Multiple choice being making our lives a lot easier because there was a distinct correct or incorrect response for these. We know that the model's correct if it gets the right multiple choice, and showed that PathChat, maybe unsurprisingly, because it's specifically trained for pathology, does better than these other models that are not trained on anything related to pathology, though, GPT-4 is scraping the entire internet, and so certainly has pathology knowledge baked into it. And maybe gratifyingly to me as a pathologist, all the models do better when you give them some context. So maybe instead of just an image and asking it to make a diagnosis, giving it a little bit of clinical context, saying like, this is the age of the patient, this is where that tumor is from, et cetera, et cetera. The other thing we did, which was very time consuming for evaluating, was using these open-end responses. And so here's where things get really dicey, because these open-end questions like, what do you see in this image, or describe the morphology here, have no single correct answer. And, depending on the ordering of the response and that sort of thing, you can get into the weeds here quite a bit. So we recruited some pathologists, myself included, to, in a blinded fashion, review the responses for these 4 different models and rank them according to which ones we prefer. And we found that PathChat, did better than the other models. And it's, again, not surprising. PathChat specific for pathology. It's really hard to get a fair comparison here because there's not another pathology specific chatbot to compare against. But more details in the paper. And so, here's an example where all the models did not do, actually PathChat did well, the other models didn't do so good on this open-ended question. So this is kind of a small image, but this has like the characteristic oligodendroglioma fried egg cell morphology, and PathChat was able to pick that out, whereas the other models seem to rely heavily on the information that's in the text. And so this description of this patient is very consistent with a glioblastoma, but the image is not consistent, or more consistent with an oligodendroglioma.
Just a quick question. How big is the size of the image that you're able to provide? Is it just a patch, a tile, or give it a whole side image?
Yeah, right now it's just tiles. In the current version that we're working with, it's up to 1024 pixels on a side, but still like, yeah, single tile. And this is all PathChat 1. We're working on PathChat 2 now to expand the capabilities. And PathChat 1 could only use a single image. PathChat 2, we're expanding the context length here so it can interpret multiple images, but we're having a lot of issues there too, where in theory, we can give it 8 images and it'll be able to interpret all of that. But often when we ask it questions, it'll think we only gave it 4 images. So we say like, describe these 8 images, and it will give us 4 responses. And so it's not great, or not perfect. So, in this sort of thing, there's tons of open questions, all kind of relating to like limitations of our work and any kind of chatbot like this. And I think maybe most importantly is like, how in the world do you evaluate this for clinical use? And or is this even possible to do, and is it desirable? Like, should the response of a model like this ever make it into the medical record, or should we always have a human there to work with this model themselves? Maybe it's the pathologist, maybe it's a treating clinician, who then interprets what the model says before anything goes into the patient's medical record. But especially with these open-ended questions and the propensity for these models to hallucinate, it gets really, really dicey. And so we had many, many examples that we didn't show in these cherry-picked examples I presented where the model will hallucinate things. So we'll say that, we'll ask like, what is this image of a lung core needle biopsy? And the model will hallucinate that it's from a 35-year-old female or something like that. And that specific example is like easy to catch. But if you're a busy provider and you're reviewing maybe hundreds of these per day, I can imagine it's really, really easy to let something slip. As we know from, there's all sorts of errors that get propagated in patients' clinical notes, that people are just too busy to read every single word and interpret every word of every patient note. This one is kind of important. How do you deal with outdated information here? So the sort of nature of any model is that you're training on retrospective data. And for this sort of natural language-based model that produces text, this can get a little hairy. And so this glioblastoma example I showed you, the model actually calls it a glioblastoma multiform, which is outdated terminology. So since 2016, we've been calling these just glioblastomas. But because the training data for this model includes text from the 1950s and forward, it's difficult to know, like, what do you do with that outdated information? And it'd be impossible to, or very difficult to hand encode. Like every time the model wants to say glioblastoma multiform, you have some manual check that translates that to glioblastoma. But what do we do with that?
I can think about head and neck, AGCC 7, AGCC 8, AGCC 9.
Oh yeah.
You know, so keeping up with all of that.
It's tricky. I think this is an important and overlooked work that I know ChatGPT is going through a lot of hullabaloo from the New York Times and other places of like, we use textbooks and we use journal articles. I think there's an argument to be made for our work because it's research only. There's no money to be made here. We're not attempting to make any money from this model, that there's a fair use ability for us to use that as training data. But that's not going to fly for commercial versions of any sort of model like this, and maybe shouldn't fly for our version as well. And so how do we properly acknowledge the authors of all those textbooks that we used or the journal articles? And if anyone's making money, how do we make sure that they get compensated for all the work that they put into that? I think another important one that educators outside of pathology are grappling with is, what should the role of these tools be in education more broadly? Should this model, if it were really good, could give you all the answers as a pathology resident, and then maybe if you don't have access to it at the next hospital you go to when you get a job, are you a worse pathologist? Or are we in the situation where when I was learning math in middle school and high school, I heard over and over, you're not going to have a calculator with you when you are out in the real world, but now we do have calculators with us. So who knows? And then I think an important next step here is these sort of agent-based models. So PathChat is not very good at things like counting mitoses or identifying the location of things in an image. And maybe if we link this up to a specific tool that was good at doing that, we could get some extra capabilities here. I will end with a joke. So I think the guardrails that we used weren't perfect. And so I was able to ask PathChat 2 a joke. I don't know, I'll just read the joke out. Pathologists are often asked to diagnose diseases, but they're not always sure of the prognosis. That's why they always carry a "sorry, I'm a pathologist, not a psychiatrist" card in their back pocket. I don't know what that means. And it's not a very funny joke. So, or maybe a joke at all. So,
I think it's.
oh yes, the psychiatrist who works with pathology data. Perfect. So yes, some severe limitations on the humor of these sort of things. All right, so I'll end there. I'll leave up these open questions to spark your discussion. Happy to take questions myself or comments about any of these questions. So thank you. Yes. Yeah, so we have this parameter in the model called temperature that deals with that probabilistic nature. And so for all the evaluations we made it so the model was deterministic, would always give the same response. But it's not clear to me, like, when would you want some temperature in your model so it gives different responses? And certainly in generating some of these cherry-picked examples, we had to turn up the temperature so it would give a different response. But for the evaluation, we kept it deterministic. Yes.
One of the problems that we have on a regular basis is learning. We have so many cases that we can pull out. I mean, at least a dozen a week that we have this problem on a regular basis. We are doing all sorts of reunions to try to validate because many times the patients have more than one tumor, and It's a real challenge. Would that be of something of interest?
Yeah, definitely. And I guess I would say that this ChatGPT may not be the best model for that sort of thing. I think this sort of chatbot is going to be decent at everything, but is never going to be the best choice for a specific problem. So I think for something like that, maybe doing another version of this that you can still talk to, but hooking it up to something that's been specifically trained for cancers of unknown primary, and we can talk about that. But I think, foundation models in general, I think of as kind of a strong baseline for the problems that they were trained for, but never the best solution.
Basic feature of any data is plan the texture and upper stage. You go to find stew, that's why the foundation of the world is developed. That's why that's you next team will come and take the foundation and fine tune it or you go to customize it. Yeah.
Yeah, I think we're way over time. So maybe we'll call it here. Thank you, everyone. Thank you.
Congrats on the symposium, congrats on the trade.
Thanks for all your support.
I gotta run, my son's texting me, I gotta go pick him up. See you. Thanks.
Goodbye to everyone. Okay, thank you.
I have one question.